I wanted to bat cleanup here and talk about the work really of some of my collaborators that I've mostly been doing some downstream blocking for. Apologies to Cosimo and Rashika and Mara, who have seen part of this a week ago at UCSF. But I want to tell you about three brief stories that are emerging translationally in my group and really the pancreas cancer group larger at UCSF, looking at quantifying histology, looking at CT scanning in a quantitative manner in resectable pancreatic adenocarcinoma, and finally looking at advanced imaging modalities in namely PET MRI and metastatic disease. Now, all of these vignettes are going to use the Homo sapiens model of pancreatic adenocarcinoma, so some of this may be a little fish out of water. But I hope to really use this as a laboratory with you guys, because we're the home team here, and I think we have some spectacular opportunities for collaboration. Everything I'll tell you about today, I want to start with, is clinically available right now in every one of your hospitals. So there's no gadgetry, even though the gadgets do sound exciting, required to do any of this. Whether you want to do it, maybe, is up to you. So the first story has to do with something that Sunil introduced us to early in the morning, and we've struck upon many times today, and that's the stromal reaction in pancreatic cancer. And this isn't focused on defining it, but actually quantifying it. And rather than thinking about what the individual molecular makeup of this is, let's just assume, like the hockey players say, you want to be where the puck is going to be, not where it is. So let's assume that we have agents in the clinic that can productively or deleteriously modify the stroma. How are we going to measure those in patients? And that's what this work is focused on. So the experimental system here was really pioneered by Tony Hollingsworth at Nebraska, who has a rapid autopsy series gathered from cadaveric patients who have passed on from pancreatic cancer. Metastases are harvested in a methodical, protocol-driven way, as is the primary. And they're tiled on a tissue microarray, which is then stained with normal H&E that's in all of our path labs and quantified using fairly high resolution but pretty standard optical imaging, apereo scanning. The patients were 12 in number, all of whom had a pancreas in place, not resected, and had a variety of metastases to the lymph nodes, the peritoneum, and solid organs, mostly the liver, also the lungs. We set out to actually take the emotion and subjectivity out of quantifying stroma and asked a computer to do it for us. So using image training, we tried to circle the epithelium and then calculate the total stromal density in a given H&E section per micron, quantify it, divide it by the total number of microns in the slide, and place that number in an Excel spreadsheet. We didn't tell the computer where the tumor came from, or even if it was a tumor, we just asked it to do what it does. And this is a representative solution the computer arrives at. You can see that there's a mix of cellular and acellular stroma, epithelium, and glass. This varies between tumors. Yeah, it's showing up better. Where some tumors have more, less stroma, some have more cellular or acellular stroma. But the point being is that there's no human touching this. This is a computer making this assignation. Comparing it to pathologic human being-driven estimates of cellularity, it's fairly accurate. I don't really care about this point. I'm glad it's not anti-correlated, but the point is it's reproducible, portable, and objective in nature. Bobby Torphy is the medical student who wrote the algorithm, and so we're calling it his index. Tumor stromal density is TSD. I'm sorry for not explaining that earlier. I think the most striking example of its utility is actually just looking by metastatic and primary site. You can see that whereas Many pancreatic primary tumors have abundant stroma that is demonstrably less in solid tumor metastases by this metric, but interestingly about equal in peritoneal deposits for reasons we don't totally understand. Maybe the surgeons are more familiar with that. Lymph nodes are somewhat intermediate, and this is highly statistically significant, albeit across only 12 patients with multiple pairs of tumors to test. But it is a genotypically matched set. Individual patients do vary. So one patient A through D, 4 patients here. Some have an almost totally stromal-rich primary that always decreases in the parenchymal metastases in its stromal index, whereas others have a little more variability, a little more cellular tumor here, but still becoming much more cellular, or 1 minus the stromal density in this setting. So through a collaboration with Julia Johansson and Herlev Hospital in Copenhagen, we had over 250 resected pancreatic cancers going back over 25 years at her hospital. Gemcitabine only became the standard of care in the adjuvant setting in 2005. All of these samples were gathered before that, so this is a purely prognostic data set of patients who were resected for adenocarcinoma of the pancreas and then not touched again until they recurred. So while this axis is a bit compressed, having a high stromal density is a favorable prognostic sign in resectable pancreatic adenocarcinoma. And while it doesn't look very impressive here, it almost doubles the survival at the median, having a higher low stromal density. So stromal infiltration in the primary tumor appears to be a protective mechanism. This is just one more vote in this controversy that everyone seems to have an opinion in one direction or another. So to conclude the first part, I would say that there are differing amounts and almost certainly characteristics of the stroma at different anatomic sites in pancreas cancer, and we need to be ready to study those because when we give a drug, it goes everywhere if we're lucky. And that there may be prognostic implications or subclasses of stroma that may be manifest and quantifiable by these metrics. And I do want to just point out that the Halozyme trial is using an entrance criterion of high HA, and this would be kind of one orthogonal method to maybe complement that sort of biomarker going forward. So the second part, again, uses just off-the-shelf CT scanning. The second part of the talk, this time again in resectable pancreatic cancer. The motivation was that we would like to preoperatively classify patients' a priori risk of recurrence and potential benefit from surgery to prevent the 3 to 4 months of recovery that all too often is followed by a relapse within 10 months, where we're not doing patients any favors. It was also based on convenience. We don't want to build a special gadget that will only work in one part of the country. Everyone has a CT scanner, and that's the standard practice. So this is based on the idea that Sunil introduced us to, that diffusion of anything, contrast or macromolecules, is a function of 3 compartments: intravascular, intracellular, and extracellular space, and that these can be quantified roughly using various imaging agents such as contrast. Now, I like to think of this as no thing is absolutely true, but a continuum of over time. Pancreatic cancer imaging is typically performed at 3 time points, and blood flow is also continuous, but a contrast bolus is focused in time. So as we delay from the point of giving contrast, we're able to interrogate different components of the extracellular and vascular structures of the tumors. So we looked at 48 patients in our center who were all resected who did not receive adjuvant therapy as a plan, and used multiphasic pancreatic CT scans by protocol. They have 3 phases like I talked about: non-con, pancreatic phase, and Portovenous. You're not supposed to know what those are. They're pictured here. Non-contrast is what it sounds like. The aorta does not have any contrast in it. The pancreas here is imaged, and we normalize with the aortic contrast to get a delta contrast index to look at the enhancement of the pancreatic tumor by phase. So non-contrast, pancreatic or portovenous or delayed phase. Pancreatic phase is typically vascular enhancement. This phase is called delayed enhancement, which pancreas cancer, cholangiocarcinoma, and some other diseases with a high degree of fibrosis are famous for in imaging circles. They display late enhancement. So that's what people are talking about. Here's a few examples. This is almost isodense with the aorta. This tumor is much lower and has a lower ratio. Okay, I'll skip this. So these are the numbers when you measure 50 patients. The pancreatic phase of imaging shows low enhancement, like we know pancreas cancer to be, but the portovenous phase is both more variable, so there's a wider range here, and higher. So these are late enhancing tumors, but there's variability amongst patients as to who enhances late and who does not. Does that matter? We set cut points for statistics at the median, 0.16 or 0.4 for this half and half dichotomization, and did multivariate and univariate statistics. Tumor size and differentiation were highly significant, as was a low ratio of enhancement was indicative of a poor prognosis. Multivariate correction, pathology went away in size as a statistically significant feature, but this normalized tumor enhancement ratio remained highly statistically significant with a hazard ratio of over 5, meaning if you do not enhance late or are poorly stromal possibly, you are highly likely to recur. This is that same data plotted by the Kaplan-Meier method, showing again that patients who had this robust late enhancement were really protected from recurrence in the absence of adjuvant therapy. Excuse me, sorry about that. So to conclude the second part of the talk, again, I think low enhancement during the portovenous phase is predictive of poor prognosis, and that contrast retention in the primary tumor may imply a favorable biology at that late time point. So this, again, something that is an indirect measurement of stroma. High stroma may be protective in the setting of primary pancreatic cancer. There's obviously future directions in that I didn't write down but are pretty obvious. We need the same patient to do the first thing that I showed you, the H&E quantification, as the second, the CT imaging, and then hopefully the third once we get the drugs to modify the stroma in real time. So the third and final part of the talk is focused on the advanced setting, metastatic disease, which unfortunately we treat too much of in the clinic. I'm a medical oncologist, so this has been my pleasure to be really running lead, finding patients, and trying to get this executed with Jane Wang at UCSF, who's my radiology mentor. We don't really have very good biomarkers of response in pancreatic cancer, and patients don't have very long to live. CA19-9 is a secreted biomarker commonly used in the clinic, but its kinetics, at least in the short term, are quite unreliable. You can see that patients who are ultimately destined to have a benefit at around 4 months here can have increases and then decreases in CA19-9, making its utility in the short term for decision making problematic. I will say that while this may seem trivial, like a tempest in a tea kettle, it is not, because 50 days is really a substantial part of these patients' survival time. So if we're dithering around with therapies that don't work, we'd rather know it at 2 weeks rather than 2 months so that we can get on something else. Currently, we don't really have a good way of picking therapy. We really choose our therapy between nab-paclitaxel, gemcitabine, and FOLFIRINOX based on toxicity more than any given biological attribute. So there may also be things that we can image using PET and MRI that may tell us which drug to use. So we took all comers, patients who were getting treated with systemic therapy in advanced pancreas cancer, with the following hypothesis: that we would see early. We started with a 4-week. We'd like to move to 2-week, but we started for 4-week decline in FDG on the PET scan and an increase in the ADC, apparent diffusion coefficient, from a diffusion-weighted MRI. PET FDG is something we all probably know and love. This is just a function of glucose metabolism in a readout, and is high in many tumors. We don't use it very much in pancreatic adenocarcinoma, mostly because CT is much more anatomically accurate for staging the disease, especially in the liver. But I think its use is emerging in functional studies that we're increasingly doing in the disease. Diffusion-weighted MRI is a bit more esoteric. It has to do with the movement of water molecules in and out of the extracellular space. And as there's increased diffusion, that may be indicative of low stroma, whereas a acellular stromal matrix may restrict diffusion, although these are still very much hypothetical and have not been directly measured. Here's an example of the apparent diffusion coefficient map that can result from imaging a pancreatic adenocarcinoma. This is the protocol. We did a pre-treatment scan and then a 4-week scan, and then compared that to a CT scan about 2 to 3 months later to see as the final adjudication of response. Here's an example of one of the patients we've treated. We've only treated about 9 patients on this protocol so far, unfortunately. The first patient had a great FDG response in the primary tumor. Here, the metastasis is not seen in this cut, and an increase in the apparent diffusion coefficient in the primary tumor, possibly reflecting a clear out of the stroma through therapy. Nicely, CA19-9 behaved properly in this patient as well and had a rapid decline, and the patient ultimately had a nice response by CT. So here everything worked, high fives all around. Now, there are cases, however, where there's more confusing presentations. Here's we got lucky enough to show you the metastasis in the primary in the same plane. An ADC of 129 that went up to 159. This showed a mixed response. You can see there's not a total resolution in the primary, but the MET actually looks like there's quite a robust response by FDG, and that the ADC here had only a mild increase, reflecting a possible suboptimal response, at least not body-wide. And here's one of these gotchas where the CA19-9 actually goes up in a month and then eventually goes down. This patient did go on to have a partial response by CT. A final case showed no change in size and only minimal decrease in the FDG uptake of the tumor, actual decrease in the ADC, and this patient progressed but did not make CA19-9, as about 25% of our patients do not. So we need markers for them, and this was an early response of this therapy, unfortunately not working. So here's a summary of 6. We're up to 9. We would love for you guys to pick this up too and add some. We see sometimes where the PET MRI is not additive. and others where it may actually give us an early signal of imminent failure that we could be able to act on at 2 weeks or a month instead of waiting 3 months. So I hope I've convinced you, at least in part today, that the biophysical properties of primary tumors and their mets potentially are measurable with tools we have in the clinic today. It's just a question of working with our pathologists and radiologists properly to correlate what we're seeing on the slide with what we're seeing on the scan, and that is easier said than done. And that the biophysical properties of metastases may not always mirror those exactly of the primary tumor. I think we need to be cognizant of that as we jump into the pool of stromal modification with both feet. It's going to be interesting to see how both the HA levels in the METs as an inclusion criterion differ, as well as the eventual responsiveness of these patients in primaries versus metastatic lesions. And I think that we have the opportunity today to use dynamic imaging to really make early decisions potentially in these patients who really don't have a lot of time to mess around, and that I think there's ethical equipoise in changing a therapy that's almost certainly going to be ineffective early rather than waiting for later time points for that progression to manifest. Oftentimes you can't treat these patients a second time and they go into hospice. So we need more patients. We'd like to fold in other parameters that we've talked about today, like RNA subtyping and cell-free DNA kinetics, and obviously the biophysical components that we've heard about today are going to be an obvious correlate in the lab if we can get these tissues out of the patients in good shape. And I think really there's another field that we didn't talk about in pancreas cancer, but we desperately need. We need more guys and gals in this area here that can really integrate these technologies that are really exponentially improving in almost every field of medicine. And we really need some utility infielders who can help us build iteratively in this overlap of biomarkers in the clinic. And I really want to acknowledge Jane Wong, Jen Ye at UNC, and Bobby for the really collaborative experience it's been working with them, and welcome any questions. Thank you.